I have the pleasure of introducing our speaker. Dr. Devin Oller is a primary care and addiction medicine physician, served as one of the first rural health leadership fellows and chief resident at Massachusetts General Hospital before coming to UK. He's an associate program director for the University of Kentucky Internal Medicine Residency Program and is an investigator on the NIH-funded Healing Community Study. Welcome back, Dr. Oller.
I don't have any financial disclosures. Today, I really want to talk about a framework for thinking about chronic pain. Many of you are not clinicians, and so this will be germane to you because I think it will give you an idea of what clinicians are thinking about when they're seeing your patients or your loved ones and trying to figure out how best to help them live with chronic pain. I think it will also be helpful in thinking through the unique challenges for folks who are living with an opioid use disorder or other substance use disorder and also navigating pain. And then lastly, I think it will hopefully give you some language and some tools to use with your clients to think about pain in a different way. I have to admit, this is something that I still struggle with day to day in trying to help my patients navigate. There are no easy solutions here. And what I often tell patients is that only they are the ones who are living with that pain. And I can't even begin to understand what they go through on a day-to-day basis. But I do want to help. It's just a real challenge to figure out together how best to help. So the framework that I want to share with you is the TLC framework, and I could show like the amazing band from the 90s TLC on here, but I feel like you guys know them well. But TLC means something different here. So it's talk about it, focus on loss of function, and trying to regain some of that function, and collaborate. And these are really our buzzwords, our sort of mantras that we're going to use throughout our evaluation of folks living with chronic pain. So let's dive into each one of these. And hopefully you guys have some questions and comments as we go along. And I'm happy to answer those at the end of each segment here. So when we're talking to our patient or our client about pain, one really important thing to emphasize is that they're not alone. We know from CDC data that about 1 in 5 people in the US live with a chronic painful condition. We'll talk about some of the data a little bit more within the opioid use disorder population. But in that population, it's closer to half or 50% of folks entering treatment for opioid use disorder are living with a painful medical condition. And really the other really important thing to emphasize from the outset when somebody is dealing with chronic pain is that your pain has a source. It is real. It is not just in your head. And even when we don't locate a tissue or a nerve or a specific muscle that's been damaged or see evidence of that damage, we know that that pain is real. We know that it is causing discomfort and loss of function and limiting your ability to live your life. Sometimes as clinicians, we separate pain into different categories because different treatments can sometimes be helpful for these specific categories of pain. So nociceptive pain is really often from inflammation of a specific tissue. So we think about sort of joints, trochanteric bursitis, inflammation within the stomach causing a peptic ulcer, angina. So actually when your heart doesn't get adequate blood supply and some of that tissue begins to break down, kidney stones, arthritis of the knees, of the hands, of the shoulders, all those cause nociceptive pain and share some of the similar sort of pain mediators at that site that are sending that pain signal. Neuropathic pain is when there's been damage to the central nervous system or peripheral nervous system. A lot of folks living with opioid use disorder or other substance use disorders have hepatitis C, and hepatitis C is a risk factor for developing peripheral neuropathy. Alcohol itself is a risk factor for developing peripheral neuropathy, nerve pain, often of the legs and the hands. And so that's something that we see a lot in this population as well. And then neuroplastic pain is an area of pain that's under a lot of investigation right now for us to better understand. It seems that there's multiple things going on in this type of pain. And often these are difficult entities to manage and treat because there's not one specific target that we can go after. So fibromyalgia, bladder pain syndrome, or chronic pelvic pain, irritable bowel syndrome, all of these sort of make up neuroplastic type pains. And people may cycle through different types of pain over the course of their journey with chronic pain. So it's important for us to continue to reevaluate, are there new sources of pain here that we can directly target and improve? The reality is that many people have some mixed or overlapping types of pain that they're dealing with. And so not one single drug or one single intervention is going to get us to where we need to be. We do know that despite these different types of what's causing the pain, there is sort of this central pathway that happens in chronic pain. And it increasingly looks like the glial cells in our central nervous system and peripheral nervous system are involved here. Glial cells almost act as an amplifier or a damper for pain signals. And chronic pain occurs when these signals get stuck in this negative feedback loop. We just can't, we're constantly playing catch up with our pain. And stimuli that to other people may not cause significant pain can really throw somebody into a crisis when it comes to someone dealing with chronic pain. And so we're increasingly looking into and investigating, are there things that we can do at this level, at the glial cell level, to help modulate that pain signal itself? So we're talking to our client, we're saying you're not alone in dealing with this pain. A lot of people are going through this. Your pain has a source. Even when we can't locate a specific tissue or nerve that's damaged, we know that you're dealing with this pain. And as doctors, as clinicians, historically, we've done a really bad job at understanding and responding to people living with pain, especially those who also are struggling with addiction. So I am here to listen. I'm here to learn alongside you and better understand how I can help you. So these are really important sort of ground rules or things to set out when talking with a patient about their chronic pain. We know that there's been disparities in how we've been managing pain. Just looking at sort of acute pain, so people coming into the emergency room, numerous studies have revealed that non-white patients are less likely to receive opioids, even when there's a clear indication for them receiving opioid therapy in the emergency department versus white patients. In several studies, Hispanic patients were less likely to receive opioids than non-Hispanic patients in primary care settings. So this is not just in the acute care setting, this is also in our outpatient settings. Often we work with learners, so residents or medical students, and folks seeing a resident were less likely to receive higher dose medications than those being treated by faculty physicians or nurse practitioners. And there's a lot of things at play here. There's several studies that point to less time per appointment or less time per session with folks that have traditionally been the victim of racist policies and other things like that, as well as access to care. So actually getting folks in with chronic pain, getting them adequately evaluated by experts, by subspecialists, are also contributing to these disparities. Even when that patient arrives during the day to an outpatient clinic, there can be bias at play in terms of clinicians. We get tired towards the end of the day. We make sometimes snap decisions, and we actually see compared to earlier in the day, if you focus on the graph in the lower left-hand corner, sort of those first couple appointments in the day versus later in the day, there's more likely chance that provider is going to give a script for an opioid prescription later in the day than earlier in the day. And it may not be that that's the result of a clear indication for that medication. It may be the result of that fatigue and really the requirement in managing chronic pain of spending time understanding how you can best help your client or your patient. When looking specifically at disparities in chronic pain management in folks living with opioid use disorder, as I mentioned before, this is a good chunk of our patients. One study showed about half of folks entering treatment for buprenorphine or methadone reported a painful condition that they were living with. We know that when folks are just managed for opioid withdrawal in the inpatient setting, and then are sent out, one risk factor for continued use or a return to opioid use is ongoing sort of persistent pain syndromes that somebody might be dealing with. So it's a risk factor for relapse. It's a risk factor for somebody coming in. And they may be less likely to receive other recommended health screenings and preventative care. Things that might have caught a painful condition earlier on get skipped over, get missed because folks living with opioid use disorder often receive subpar care. And then there's this other piece of it where this cycle of sort of provider distrust is internalized, and folks living with opioid use disorder and other substance use disorders begin not to trust or take at their word their clinicians, their providers, understandably because they've been treated poorly in the past. And so when gold standard treatment regimens like physical therapy for lower back pain are recommended, folks with opioid use disorder are less likely to complete therapy. There's a lot of factors at play here, but I actually wanted to pause and see if others had ideas about what might be contributing to some of these disparities in pain management for folks living with opioid use disorder or who use drugs. And any other thoughts or things that you have experienced on the disparities side of things? Mental health issues. So I'm so glad you brought that up, Andrea. So that is actually, when we look at sort of outcomes in folks with opioid use disorder, and we also look at folks with chronic pain who develop an opioid use disorder, it's less likely sort of the amount of opioid prescribed, and actually more likely do they have a comorbid mental health condition that somebody that puts somebody at higher risk for developing opioid use disorder when they're on chronic opioids. Anya brings up a great point that a lot of time they are not believed, right? And so that's why it's so important that the first words out of that clinician's mouth is, I believe you, you're not alone. You're living with this pain. Let me try to understand it a little bit better. When he brings up poverty, and that can be a huge issue when it comes to accessing treatment, right? They may have insurance coverage, but can they cover sort of copays for medication or additional procedures? And Shirley, I really appreciate sharing your own experience of sort of being sent to mental health evaluation and having lupus and that diagnosis being delayed. And that gets back to my previous point of a lot of care is delayed or diminished because of clinicians not taking the time and the respect to understand folks living with a substance use disorder. Bias. Michael makes the point that when they're using drugs, sometimes that physical pain is masked, and then they enter recovery. Oh my gosh, now they're dealing with this chronic pain, and the coping strategy that they know worked using is no longer something that they can access, right? And so they struggle sometimes to grasp at what is going to help. Okay, I really appreciate all those contributions, and I think you're absolutely right. We can't sort of put our finger on one or two or even three things at play here, and it starts with though that central respect and trust, and trying to gain that with patients. So one thing that we can do in trying to better understand the pain that somebody's living with, if we ourselves are not dealing with that, and I'm open with my patients that I'm lucky that I haven't lived with a significant chronic pain issue, is trying to understand the metaphors or the sort of the narrative that patient is developing around their pain. This comes from actually a project that Columbia put together for folks newly diagnosed with cancer. And they sort of said, here's a menu of different things that people use to make sense of and better understand their cancer diagnosis, right? And some people sort of call it like an unwelcome guest, or sort of they were going through life and everything was sort of a happy tune, and now we're at like the dark, depressed tune. A journey, sort of like a weed in the garden. So these were terms that folks use for a new cancer diagnosis, but I think a lot of them are applicable to dealing with chronic pain. They might describe sort of this constant battle that they're in to get through the day, or they're on this roller coaster ride where some days feel really good and the next day they're plummeting down to the depths and really scared about what's going to happen next. And so the better we can understand how they best understand their pain and what it feels like day to day to live in that pain, I think the better we can help them out. One metaphor that I find myself using is that of a car, and this is to explain a little bit more this idea around how chronic pain is not just sort of the damage at that tissue level or at the nerve level, but it really is a change in how our body is processing pain signals. So I say, your body is like a car. The more damage or pain you live in, the more you're forced to adapt. And even when you fix the damaged parts, those adaptations, the things that you did to get through the day, what you and your body changed to survive, those might persist, right? That's sort of the best description of chronic pain. So if you have a car and you graze sort of a side of the other car and you have a scratch along the side, it's a common tendency for you to then drive a little bit further away from that car that might be going next to you. But then you might be bumping against the median, right? And causing more damage to your car. And chronic pain is like that. We force ourselves to try to get through these adaptations, and we may be causing more damage that way. The other thing to understand about chronic pain is that there's actually different cultural understandings of pain. When we ask, say, Nepali patients, of which actually Lexington has a fair amount, Nepali speakers rarely use expressions like sharp or throbbing, which are common in English, and may alert a clinician to, hey, this is a really significant or severe pain. And they also have words for pain without direct translations into English, such as kat, which is this achy sensation that can feel deeply cold. And so it's impossible for me as a doctor to treat that pain unless I have a better understanding of what that pain feels like and how it might be able to be addressed. But just know that we can't rely just on these buzzwords, these adjectives to better understand pain. Okay, so we talked about it, right? Now it's about beginning to formulate a plan. And what I think is most important when formulating a plan with your patient or your client is focusing on the things that they're really struggling with day to day, those functions that they're having difficulty with, and being able to start to build back a pathway to them gaining some of that function back. But we often get stuck talking about this. Often patients will bring up, understandably, I've tried these series of things, or my family member tried this and it worked great for them, or didn't work at all. Or Dr. X prescribed fill in the blank drug for me for years, and that was helpful. Or we might get into negotiation mode of, I'll do this if you'll do this, right? And that sort of breeds some of that distrust on both sides down the line, right? And so I think that instead of this, we should really be sort of stepping back and saying, we don't have a lot of evidence for what we use in terms of managing chronic pain. In fact, when we look at effect sizes, sort of how impactful interventions were in targeting chronic pain, psychological interventions, pharmacologic or drug interventions, interventional procedures, complementary or alternative management strategies for chronic pain, all of those studies show low or inconclusive effect sizes, right? We don't have a silver bullet for managing chronic pain. We have a lot of good options, not a lot of great options. And so we really need to be attuned to how these might help with your function. I'll give you an example. So when we look just at osteoarthritis of, say, the knee and the hip, these are various societies that provide guidelines for the management of osteoarthritis of the knee or hip. And really, where you see sort of green, that means that there's consensus. They agree that this might be something that's helpful for you. Where you're getting into the yellow or the red, it's less likely to be helpful. And you see these are non-pharmacologic options, so weight loss, physical exercise, so cognitive behavioral therapy. When you get into medications, there's a whole lot of red and yellow here, right? With really only oral and topical NSAIDs as something that's routinely recommended, and not a lot else, right? And if you or your client is struggling with figuring out some of this evidence and what their doctor might be talking about in terms of these options, the Cochrane website is actually a really good place to go. They have plain language summaries of some of the studies that have looked into everything from acupuncture for cancer pain to antidepressants for chronic non-cancer pain. So the way that I often start these conversations is I say, when we think about your pain, what 3 or 4 areas of your life does it most impact? And I might give them this menu of things to look at, right? So does your pain most impact your anxiety or your mood? Does it impact family time? Does it impact leisure time? Does it impact sleep? That's a huge one for a lot of folks. Does it impact walking or getting around, right? Concentration or focus? Does it impact our employment, right? Or our social life? Because when I understand a little bit better what domains of their life are not functioning where they need to be, we can begin to address that with either medication or other options. Because, like I said before, the benefit of that slew of options for chronic pain, everything from drugs to cognitive behavioral therapy to complementary therapies, those are sort of a wash. They have pretty low evidence across the board. So the benefit is fairly neutral. And so when thinking about chronic pain, things that we might be doing for years or decades down the line, we really need to focus as well about some of the risks of those therapies as well. So from higher to lower risk, there's surgery, injections, pain pumps, non-opioid therapy, opioid therapy, psychological therapy, exercise, right? So it's important to understand where on the continuum whatever intervention we're using might pose risk to this individual, and try to personalize that as well. So the way that I might do that when talking about medications is, because we are using these medications potentially in the long term, I want to make sure that we're choosing something that doesn't impact your sleep or your mood or another concern that they had in terms of what they were already struggling to function with. I want to make sure that this medication doesn't impact that. So if they feel sleepy all the time, I don't want to add something that's going to further sedate them. Or if they're worried about some of their heart health or things like that, I want to try to avoid some of the agents like NSAIDs that might worsen that problem. So you see a whole bunch of these non-opioid agents for both acute and chronic pain. You see a pretty long list of side effects. And so the best way to approach this, in addition to sort of setting that language up to say, this is something that we may be using in the long term, and I want to make sure that we're minimizing those side effects. What we can do is say, hey, we want to give this a trial. It's going to be a trial over the next month. And then I want to check in. Maybe it's by phone. Maybe it's bringing you back in to see how things are going. Is that risk to benefit ratio still something that you find is helping you? Or is it something that actually those risks are beginning to accumulate, or we're actually starting to see some harm from this therapy? We need to either de-escalate or come off of it. I get asked this a lot as somebody who's both a primary care doctor and addiction medicine doctor. And that's sort of this question of buprenorphine or methadone for opioid use disorder in somebody who's also dealing with pain. So if we think about the pharmacology, some of those initial KY open sessions, we know that methadone is a full agonist, meaning that as you increase the dose of the methadone, you'll get more and more of that agonist effect, that activation of the opioid receptor. Whereas buprenorphine is a partial agonist. So as you increase that dose, there's a leveling off in terms of the amount of activation that happens at the opioid receptor and its impact down the line in terms of neurotransmitters. So you would think, hey, methadone makes more sense for patients living with chronic pain and opioid use disorder. But the thing that counters that a little bit is both sort of tolerance and this condition called hyperalgesia. So tolerance is where we have to use more of a drug to get the same effect, right? So over time, we see this in folks living with opioid use disorder needing more of the opioid that they're using to just stave off withdrawal, right? And methadone, in the same way, as we get control over pain, we may have to make adjustments down the line to control that pain better because of development of tolerance. Whereas buprenorphine, we tend to not see that effect in the same way. Methadone, as a reminder, is mostly dosed through an opioid treatment program as a once-a-day medication. It can sometimes be dosed as split dosing, and that can be helpful for folks dealing with chronic pain because the peak effect from an analgesic standpoint of methadone is going to be around sort of 3 or 4 hours and begin to fade after that for folks. Buprenorphine can also be used as a split dose to help with either acute or sometimes chronic pain as well, because its sort of peak analgesic effect is going to be within that first couple of hours after a dose. So oftentimes, what I emphasize with patients is let's make sure that we are prioritizing both your pain and your recovery and achieving sort of long-term remission of your opioid use disorder. Let's have an open and honest conversation about the significant barriers that exist to getting into and staying in methadone treatment. And that oftentimes we don't see a huge a jump in terms of pain control moving from buprenorphine to methadone. And let's do everything that we can to try to optimize how we're dosing the medication, and both for control of cravings, but also for control of pain. So it's not as simple as methadone is a full agonist, so it's better for pain. It really is an individualized discussion with that patient. Any question? Let me pause there. Any questions on buprenorphine versus methadone? Yeah, so Michael, thanks for bringing that up. So hyperalgesia. So I mentioned that, but didn't explain it. So opioid-related hyperalgesia is this condition where, sort of paradoxically, we get the opposite response of what we'd expect when we take an opioid analgesic or opioid pain medication. Instead of getting pain relief, we're further sensitized, and we have a more pronounced pain response after taking that medication. And so that's something that actually has been shown to improve, so have less of those hyperalgesic symptoms when patients have been transitioned over to buprenorphine. And so typically, if folks are running into that issue, I'll try to make sure that they are transitioned to bup. And then split dosing. So split dosing with methadone means that they'll dose you in the morning, then often do sort of an afternoon dose. And then for buprenorphine, there's a wide variety of ways that we can do split dosing. The challenge becomes from a regulatory standpoint, different states have different rules about how that medication is prescribed. And for opioid use disorder in the state of Kentucky, at least on our script, we need to be writing it. It's recommended that we write it as a once-a-day medication. In the acute setting, often when I'm working in the hospital, I'll use buprenorphine almost every 4, sometimes 6 hours. So 4 doses or sometimes 5 or 6 doses of buprenorphine for folks dealing with more acute pain because it makes use of that peak analgesic effect a few hours after their dose. And then as they get closer to discharge, we try to sort of narrow things down to maybe a twice a day or a 3 times a day dose, just for ease of use. And this is a medication that does have street value. And so we don't want folks to have to carry around a bottle and lose that at work or have it stolen at work and then be out of their medication. And the way that we minimize that risk is by having dosing happen as much as possible at home where it can be stored safely. So we talked about some of the medications that are used to help manage chronic pain, but there's newer therapies out there that don't necessarily use medications and provide some benefit for some of those tougher to treat pain conditions. So transcranial magnetic stimulation has been found to be helpful in neuropathic pain and fibromyalgias and chronic headaches. Spinal cord stimulation. I've seen a few patients with failed back surgery syndrome or severe peripheral neuropathies that have seen significant benefit from that. Peripheral nerve stimulation, the TENS unit or transcutaneous electrical nerve stimulation. A lot of these are procedures or interventions that are done through a pain specialist. And we want as much as possible, and folks who have tried multiple lines of therapy to help with their pain, to make sure that they are talking with a specialist about these additional options. But it's useful on the front line to make sure that folks know that there are areas of active research. You haven't hit the end of the line. There are still things that we can offer to help manage your pain, but more importantly, help get you functioning in the way that we want to. Cognitive behavioral therapy, or CBT, is one of the key facets of managing chronic pain as well. And it's really, really important to have that upfront conversation about why cognitive behavioral therapy can be useful in managing pain. And the main thing I tell patients is that that piece about sort of glial cells and how sort of shared pathway of chronic pain is that our body is hypersensitized to pain. We react and we adapt to chronic pain, and those adaptations can sometimes harm us. In the same way that that nick on the side of our car changes how we drive, right? And so CBT can help make sure that we're staying centered, and we're addressing any emotional amplification of our pain, or psychological amplification of our pain when we are going through significant pain. The ABCs of CBT, and we talked about this in a couple other KY Open sessions, but it's really working with the client to think through what was the activating event? What was the thing that might have triggered them feeling this significant pain? What beliefs or thoughts do they have about the event, right? So in the middle of feeling that pain creep up, did they start having thoughts of this pain is never getting better, right? Or, oh no, like what is gonna help with this pain? Nothing's helped before, right? And then sort of consequences, what happened, right? Did they stay in bed that whole day and because of the pain? Did they have to take more of their medication than they intended because of the pain that they were dealing with? Being able to walk through that triggering event, the activating event, the beliefs or thoughts that they had about that trigger and the consequences, then allow you to sort of take this pause. We often sort of do some mindful breathing after going into the details of those events, those triggering events for pain crises, before sort of then jumping into disputing or challenging those thoughts, and reflecting on and debriefing on some of the effects of challenging those thoughts. So this is especially important in folks with opioid use disorder for the reason that one of our participants mentioned earlier before. Individuals with co-occurring mental illness exhibit a 3.5 to 5 times greater risk of engaging in non-medical opioid use than those with chronic pain alone. Individuals with chronic pain and high levels of negative affect or pain catastrophizing. So that thought of this pain is never going to get better, or this is the worst pain ever, and there's no light at the end of the tunnel here. They also exhibit an elevated risk of a prescription opioid misuse. And there's this piece about distress tolerance too, that's probably at play here, where our ability to cope with really strong emotions, often triggered by pain flares or things that we have to give up because of our pain, that can be a factor in predicting for folks who are entering treatment with opioid use disorder. Do they have a relapse? Do they have a slip and a return to use? And that highest risk period is often that first couple of weeks after using, because as I said before, they've lost that coping mechanism that they knew that they could fall back on when they were dealing with really severe pain. Okay, we're gonna jump over our mindful breathing exercise, just in interest of time. I want to talk a little bit about some of the integrative medicine services that are here at UK and are offered around our state as well. So we talked about medications, we talked about interventional procedures, we talked about CBT as sort of some of the key foundational interventions for chronic pain. But there's also some evidence that these things can help as well. So acupuncture, which has been extensively studied for lower back pain as well as other conditions, therapeutic massage, Reiki, and virtual group exercises, everything from journaling, meditation, yoga, which has also been studied in multiple chronic pain conditions, are available. You see sort of how these copays or these additional fees can get in the way of folks getting potentially helpful interventions who are living with chronic pain though. And so really expanding access to these needs to be an important part of what we do from a health system standpoint. So we talked about chronic pain. We focused on the client's loss of function and the things that we might be able to do to try to gain some of that function back, and certainly not go backwards in terms of accruing more side effects or more harmful effects from the interventions that we do provide. And then let's talk a little bit about collaboration. We've talked throughout this about making sure that both voices are heard, but I want to talk both about some of the benefits of collaboration and some of the risks of not collaborating. So one really big area of research right now is looking at, because of pressures on the regulatory side, prescribing side, with chronic opioid therapy, we've seen more and more people either tapered or discontinued off of their long-term opioid therapy. And we see huge risks in that population in terms of developing heroin use after discontinuation or taper, as well as other illicit opioid pain reliever use. And within a pretty short period, so I think this was for 90 days after discontinuation or taper, you saw about sort of half of patients had emergency room related event, emergency room event related to either opioid use or withdrawal. You have mental health crises where folks have a huge risk of worsening mental health in those months after discontinuation or taper of opioid therapy. And increased risk ranging from around 60% increased risk to over 600% increased risk between less than 30 days and a year after discontinuation of long-term opioid therapy. These are huge risks. And so it's really important that when having that conversation about tapering or discontinuing opioid therapy, there's a clear plan for follow-up. There's a clear plan for how that individual is going to cope when there's a pain flare and how we're going to deal with that, right? And we should really be taking a look at every single option available to that patient and the clinician before dropping down doses or discontinuing therapy. So for the clinicians who might be joining, these were some useful steps from New England Journal perspective article that reviewed some of those recent studies. So one is, when you're taking over care from another clinician, try to review that case with the other clinician as much as possible. Get information about what treatment interventions were helpful for the patient, what were not helpful. Consider providing a therapeutic bridge. So here's a shorter script of medication, and I want to reevaluate in a few weeks and see how things are going, rather than just stopping or initiating a taper right off the bat. As much as possible, developing that patient-centered plan, focusing not just on the medication, but the other interventions that we know can be helpful for folks. Assessing for opioid use disorder and starting those medications for opioid use disorder if that's present. And then documenting your rationale for that treatment plan, especially if the choice has been made to discontinue or taper therapy. This encapsulates what really good care looks like for chronic pain. And this is taken from an article addressing chronic pelvic pain, where you first understand the biopsychosocial factors contributing to pain. You're discussing and having a shared decision-making conversation with the client or the patient about their goals, expectations, sort of when you're going to follow up, what we're going to try. That we are giving folks a menu of options and really helping guide them to the options that are most likely help with their functioning, as we talked about before. And then probably the most important part of this flow diagram is that green box down below, where we're following up at a short interval, so 4 to 8 weeks, sometimes even shorter, to see how things are going, reassessing our goals, tweaking if needed, and trying to better understand how we might be able to help them. And so I think it's useful to think about how few patients actually get this level of care, right? And if your clients are not getting this level of care, working with them to advocate with their clinicians or with other providers to make sure that all the facets of their chronic pain are being addressed. So I mentioned this earlier, but I want to bring it up again. Sort of these areas where we get stuck, where we anchor on what's worked or what's not worked in the past, or what a family member or a friend found helpful, or what a previous doctor was doing for the patient, or negotiation. And the reason that we get stuck in these conversations are often from three different places. So the first place is sort of not understanding. So this is occurring when clinicians or other providers are making unwarranted assumptions, right? So this person has an opioid use disorder, so I can never prescribe opioids for them again, right? That's a false assumption. That is not true. Or that when I prescribe opioids, they're immediately going to inject that into their arm, right? So often those conversations do get tripped up, and you guys are testament to those conversations going badly because of not understanding from clinicians. And we, as clinicians and others, need to do a better job educating those folks. More often, though, it's a misunderstanding or disagreeing, right? So misunderstanding occurs when their words or their connotations or their interpretations differ between that clinician and the client. So the client might look sort of confused or puzzled, or say things like, I don't get it, right? And that's the opportunity to sort of pause, right? Before we just get entrenched in sort of that one view of what we think is going on as clinicians. Pause and step back and say, where's the disconnect? Where am I not getting the right information? And then disagreeing occurs when the clinician and patients have each that equal set of information, right? But can't really settle a difference of opinion about how best to move forward. And often the solution to that is still showing that genuine interest, not closing the door, expressing sort of some curiosity or surprise with views on either side of that exam room table, and beginning to try to come together. I would say that another thing that I personally have found very helpful here, in addition to that empathy and that curiosity, is just offering more touch points, right? So offering you to continue that conversation in a couple weeks, right? To do a trial of something that's time limited, so that we can gather more information and come back to this discussion with information that might skew us one way or nudge us in another. So revisiting the conversation at a short interval of follow-up can be hugely helpful as well. So that's the framework. We talk about pain. We say that folks are not alone, that their pain has a source, that it's real, and that we as the healthcare industry have done a terrible job in managing chronic pain. We need to do better, and it starts with understanding what their lives look like on a day-to-day basis living with that pain. Once we have an understanding of that day-to-day for folks, we can better target our interventions at the areas where they are feeling that loss of function the most, help with those domains where folks are really struggling, and minimize the risks of our interventions, and steer away from those that might contribute to that loss of function. And then collaboration. Sometimes this takes longer, this takes more visits. And that's often another that feeds into those barriers of access and disparities that are already present in chronic pain management. But so important to take that time. And for you who might not be either in the clinician or the client side, to be a fierce advocate for your patients or your clients when they are struggling with getting answers or getting the care that they need. So let me pause there. What other questions do you guys have about chronic pain management? Okay, so Mackenzie asks, is there policy requiring providers prescribing a certain amount of pain medication to also prescribe naloxone? So the short answer is no in many situations. There are some states where on more the pharmacy side, yeah, yet. But I think we're probably going to see this moving forward of more co-prescribing or automated prescribing of the naloxone. And that brings up a really good point, which is like with every medication, we should not be prescribing something that we don't have a conversation with the patient about, right? And it's really important to have that conversation about naloxone. One, to share how it works, right? And make sure that you're getting some teach back from the client to know that they understand how it works. Two, to describe sort of their personal risk, the specific issues of why you're prescribing that medication. It's usually not just the amount of opioid that's being prescribed. It's usually also their medical issues. So they might have COPD, where they're at higher risk for respiratory depression if they're also taking an opioid. It may be that they're prescribed other medications that are sedating, and so that poses an increased risk. So it's rarely that it's just sort of the amount of opioid being prescribed that kicks them into that higher risk category. And so sharing that personalized risk, and then always leaving that out of if you feel like you do not need this, having it around to potentially save a life and reverse an overdose of somebody that you love and care about. I've had very few people push back against that as an option, right? So I think co-prescribing with naloxone makes a lot of sense. I think we need more streamlined ways to make sure that that's happening at the pharmacy level and at the clinician ordering level. And we have some work to do there, but have that conversation with your clients. And Monica says that some pharmacy chains have a corporate policy of offering naloxone. That's great. Patient can always say no, but more naloxone we can get out there. There's also a movement at Foot, and I'm not sure where the status is with this of switching naloxone over to an over-the-counter medication, right? Which would certainly increase that access as well. And yeah, as John says, you can send them to John if you prefer to be anonymous, or if you have one that we should save for next week when going through some cases, that would be awesome as well. All right, thanks everyone. I think that hopefully this gives us a good framework to think about chronic pain, to advocate for our patients. And next week we'll spend some time talking through specific cases, sort of how I would think through those cases, what recommendations I would have, and think about collaborating with you guys as well about additional input that you would draw into that case as well.